Yeah. Well, no, yeah, I don't know. I actually prefer to keep the door closed. We've had some security issues. Not that we've ever had anything major here, but if something happens, that's the only thing that could potentially save us. Not saying anything would, but you know, we've had a couple of bomb threats last year.
I'm with you.
Or actually this year.
This year.
Yeah. And so I'm just going to make a habit of closing it. It's not to necessarily punish people, because if you want to show up late, I don't care, as long as you don't get in the way of other students. But you know, I don't know. I feel a little safer with the door closed.
Don't worry, I'm here too. So
Yeah.
First line you finish, that's the door.
Yeah.
Exactly. I'm the bullet.
I'm not saying that I don't. I'm not saying that I dislike any of you, but I'm more concerned with self-preservation. Sorry. Okay, so we've got a lot of stuff to go through. How much anatomy and physiology did Paul talk about when you guys took ECG? And
Not really.
Yeah, I'd say it's
That's
about
minimal
as much.
amount.
Yeah.
Okay.
Very little.
Okay, so we'll
Very little.
everybody here's taking anatomy and physiology, though, right?
Yes, sir.
Yep.
Okay, good. So there are some basic assumptions I'm going to make.
Make
All
one.
right. That's just going to make it a little easier for us, and I think we'll be okay. So what I want to do is I want to talk about kind of the fundamental cells involved in the heart, and there are a lot of them, but we're going to talk about the fundamental cells, the myocardial cells, or the myocytes. And what are myocytes?
They're muscles.
Yeah, it's a type of smooth muscle. Specifically, what kind of muscle is it? What type of smooth muscle? Don't make this harder than it needs to be.
Cardiac.
It's cardiac. Right. Doesn't need to be any more difficult than that. Now, cardiac muscle has some interesting properties, and I want to make sure that we're all good. And I think you guys know these properties, but maybe we just haven't codified them robustly yet. So let's talk about the special properties of myocytes. What are they? What can they do that other cells can't?
They can self-activate.
Okay, and what does it mean? What does it mean when you can self-activate? What is that term that means self-activation?
Depolar.
Automaticity. Yeah. So they have automaticity. Okay, that means that they can activate themselves, and that automaticity is very important when talking about pacemaker cells, right?
Mm-hmm.
Okay, that's how your pacemakers work. Now, in principle, any cardiac cell could become a pacemaker cell if it had to, but there are special areas where you have small groups of cells that are more adept at being pacemaker cells, and of course those are what we call the nodes, right? Your SA node, and then you do have the junction, the AV junction, and then Purkinje fibers or the ventricular myocytes can potentially take over the pacemaker. Okay, so that's automaticity. What else do we have?
They could keep firing for continuous time.
Well, what does it mean to fire? What do you mean by firing?
Like contract over.
Oh, well, the firing is not contraction, right?
Mm.
And I think I talked about that with you guys when I covered for Paul for a week, right? There's a difference between depolarization and contraction, although we want depolarization to be associated with contraction.
Mm-hmm.
But since you mentioned it, contractility is one of those special properties of muscles in general, but particularly or specifically in this case, we're talking about cardiac muscle. All right, it can contract, it has automaticity. What else can it do? It can what? What else can it do? Need water in, wasn't machines. Okay. What else, guys? What happens when it depolarizes? What's going on?
Has electrolyte exchange?
Yeah, what's happening is that's moving through the cell. What's going on there? It's kind of in the name of what you guys spent all summer studying. There's a system that you guys studied all summer.
Sodium potassium pump, right?
No. Okay. Here's the SA node.
Give us a hint.
Here's the AV node. And when that goes from the SA node to the AV node, we call that what? Conduction. Right?
You got us. That's good. It's
Guys.
fine, Christopher, please.
Right. Conduction, right?
Yes.
Conductivity. It can move, those impulses can move from cell to cell. And then finally we have, and it is related to automaticity, but I'm going to get kind of separate because it's something that we can tweak a little bit, and that is excitability. Which is related, okay, to automaticity, in that if your cells become more excitable, what happens to automaticity? Yeah, it increases, right? There's more automaticity. So you could say that excitability is kind of an emergent property of automaticity. All right, are you guys okay with this? Does this make sense?
Sure.
Right? Because it kind of felt like a struggle getting through. So I want to make sure, because I don't want to see this today, and then when you take your block exam, you're like this. Okay. I don't want to see that. Right? I mean, the tears of students sustain me a little bit.
Yeah, that's your favorite.
But the problem is, when people fail out, I don't get paid, I don't make tenure. There are all those really important things that involve me, and that goes back to that whole self-preservation thing. Right? No, but are you guys okay with that?
Yeah.
And that makes sense, right?
Yeah.
Okay.
Is that all of them?
Huh?
Is that all?
Yeah, those are the major ones that you need to be familiar with. Okay. Now there are some other terms, some basic terminology that we need to be familiar with. And these terms will definitely show up on exams, quizzes, etc. Okay? So when I talk about the heart, about cells firing and whatnot, there are special terms that mean pretty mundane things. And so the first thing that I'm going to put up is chronotropy. What's chronotropy mean? What does that mean?
Reminds me
Anybody?
of chronotropic.
Yeah.
Chronotropic, inotropic, all those good
Yeah, all those words. Yeah, what do they mean?
Is that one rate?
Yeah, right?
Yeah.
You guys studied mythology in high school, right? You had to, right? Is that like a big, right? Remember Kronos, the god of, right? Time, right? Going back, right? Yeah, Kronos. Yeah, well, nobody wears,
No.
very few people wear, but chronograph, right?
Fancy watch.
Yeah.
Yeah.
Well, everybody has eye watches and whatever else. Yeah. But are you guys okay? Chronotropy. So when I'm talking about chronotropy, what really am I talking about? I'm talking about what? Rate. Right. Heart rate. Yeah. Let's keep it simple. So whenever you see some complex paragraph talking about chronotropy, we're talking about rate, right?
Mm-hmm.
You just marry those two things. It's just a pretentious way of saying rate. Okay? That's all. Just a pretentious way of saying rate. So if I give a medication that has positive chronotropic actions, what's that going to do to my heart rate? And if I give a negative chronotrope, that's going to do what? Right? If I'm talking about positive chronotropy, talking about increasing heart rate, negative. Guys good with that? Yep. Good? All right. All right, so let's talk about inotropy. Okay. So what does inotropy refer to?
Is that like the actual, like,
Say it.
Contractility.
oh, yeah.
There you go. Yeah, contractility. All right. How hard the heart beats, how hard it contracts. So if I give a medication that has positive contractility, okay, what does that mean? It's a positive inotrope, right? And it does what? It causes the heart to contract harder, right? Now, negative is keeps the heart from beating as hard, right?
Yeah.
Now, can you have drugs or conditions that can maybe increase one and decrease another? Or vice versa?
Yeah.
Or increase both or decrease both? Yes. For example, if I give dopamine, let's say that I give 15 micrograms per kilogram per minute of dopamine, what at that dose, what would you expect dopamine to do?
Positive inotropic effects.
Positive inotropic effects. What else? Anything else? Anything else? At 15 micrograms per kilogram per minute?
Increased heart rate.
Increased chronotropy, right?
So it's both positive.
Right. You guys are good with dopamine, right? It's triphasic, or it's traditionally we call triphasic drug. You studied this in pharm. I'm pretty sure this is one of the meds you study in particular, right? You know, at the lower doses, it has more chronotropic, right? Hopefully you guys know that because we talked about that in ACLS last week, right? And you give your 5 to 10 micrograms per kilogram per minute dose has more chronotropic effects. And then once you go above 10,
More inotropic.
you start adding inotropic effects onto that, right? You guys good with that? Does that make sense? Now let's say that I administer a beta blocker, like metoprolol, cardioselective beta blocker. What is that going to do to my chronotropy and inotropy?
Negative chronotropic effects.
Okay, so it's going to have negative chron, so it's going to slow the heart rate down, and is it going to have any inotropic effects?
Negative inotropic.
Yeah, it's going to have some negative inotropic, so it's going to make the heart contract a little less vigorously, right? So you can see, and then there are some meds. What if I give adenosine, for example? You guys remember talking about that and going through giving that in the lab last week. What is adenosine going to do? Primarily, what is it going to do?
Negative chronotropic.
Yeah, its primary effects are chronotropic, right? Right, to the point of maybe even stopping the heart for a few seconds. Yeah. Does that make sense?
Yes.
Okay. You guys okay with that? Good with that? All right, cool. There's another word, all right, that occasionally comes up, and that's dromotropic. What can you guys tell me about dromotropy? Don't be afraid to look it up, too. Don't be afraid to Google. Be a Google scholar. Go Google scholar on me.
Google scholar turned ancient scholar. What would you say?
Yeah, just Google search it. You'll be all right.
Just
Or
shut
Yahoo.
up.
Yeah. What's that?
Conduction speed?
Ah, yes. So this is the speed of conduction.
Drones.
Speed of conduction. Now, does that necessarily mean heart rate? No, what it means is how quickly is that signal moving from, let's say, the S8AV node. Now, in some cases, negative dromotropy may decrease chronotropy, right? In some cases, it may not, okay? So if I administer a medication such as amiodarone, I administer amiodarone, okay? How does amiodarone work? You guys probably talked about this in pharmacology, right? since it's kind of one of those frontline code drugs, it's kind of an important one to know. If you administer amiodarone, where does it work?
Would it be the dromotropin because it gets for dysrhythmias, right? Or it's
It's affecting the impulse, right?
Okay. I love the way you guess. Those are some good guesses. Yeah. So when I administer amiodarone, and on Wednesday, again, this is just more evidence that Wednesday is going to be a day well spent, focusing on farm for you guys. But did you guys talk about the Vaughan Williams classification of antidysrhythmics in pharmacology? No? Yes?
I don't think that rings a bell.
Doesn't ring a bell? Okay.
It might have been on our drug cards, like class 2 or class 3,
Yeah.
but we didn't actually.
You didn't really elaborate. Okay, we'll talk about that in more detail because that actually will help make more sense. But what, and I'll just tell you, while I'll just tell you what it does, and we'll go into all the nuance on Wednesday. So amiodarone primarily, well, it does lots of things, but we like to condense its major effects down to how it affects potassium channels. It slows the flow of potassium, particularly when potassium comes into the cell, and so it kind of prolongs one of the phases of the cardiac action potential cycle. So basically what it does is it takes a longer time for conduction to flow through the heart, but it doesn't really affect the, not profoundly at least, affect the SA node. So it doesn't necessarily slow the heart rate down, but it still decreases the time it takes for that impulse to conduct through the heart, okay? That's a real high yield way of looking at something like amiodarone. So dromotropy is kind of the one I think is a little more difficult to kind of wrap your head around because it's not literally the heart rate, it's how quickly that action potential is propagating or conducting through the heart. You guys okay with that? And we can have drugs that do really weird combinations. For example, a drug for heart failure, a very common drug for heart failure, let me throw that out there. What is one of the most common drugs that we give people with congestive heart failure? CHF is chronic, right? So chronic heart failure management. It's a drug you see a lot, and it's a drug that has lots of side effects that you have to deal with a lot as paramedics. No, I mean, Lasix is potentially one, is a diuretic. Warfarin is
Very different. It's very
potentially if they have AFib, right? And we know atrial fibrillation is relatively common in heart failure patients.
Like a beta blocker, you mean? Or what class of drug is it?
It's a specific drug, really, really common in heart failure patients. Hugely common. It's a mainstay therapy. It's so important that you should probably commit it to memory after today. Because it's that important and because it has so many side effects associated with it. It's called digoxin. Digoxin or lanoxin, okay? This is
Digoxin or what?
Lanoxin. This is a mainstay therapy for CHF. It really is. It is a mainstay therapy for chronic management of atrial fibrillation. That's definitely information you're going to want to commit to memory. Did Paul talk about digoxin with 12-lead ECG interpretation?
It talks about like the digitalis effect.
Yes, dig effect, right? It causes the characteristic ST depression. They're what we call the ice cream scoop depression, right? It's one of those things that can confound the diagnosis of STEMI versus NSTEMI and unstable angina because it looks a lot like a non-STEMI or unstable angina, right? You guys okay with that? Now, digoxin is a weird one because digoxin works through negative chronotropic effects and positive inotropic effects. So what does it do to the heart rate? Decreases the heart rate. What does it do to contractility? It increases contractility. So digoxin is a good drug for certain types of heart failure. Okay, it decreases their heart rate so their heart isn't having to work as hard, and it makes the heart contract a little more effectively, right?
Does it have any dromotropic effects?
A
is it just mainly-
little bit, obviously. It actually works on calcium and how calcium ions flow. A little bit, but its primary effects, not getting too nuanced, its primary effects tend to be negative chronotropic and positive inotropic. And you can see how that might be beneficial in heart failure patients. You can also see why that might be beneficial in someone with AFib, because AFib dysrhythmias tend to cause what kinds of heart rates?
High.
Very fast heart rates, right? AFib with RVR, those kinds of things. So DIG can actually help control the rate, make the heart contract a little more efficiently, but there are lots of side effects associated with it too, right? And it interacts with a lot of drugs, and we know that if our potassium levels get out of balance, you can have DIG toxicity occur very easily. Okay, so you guys good with some of this basic terminology, the basic properties? You guys okay with that, more or less? Okay, so let's go ahead and move on. What I want to do now is I want to talk a little bit about, and this should just be some review stuff, hopefully, about the basic anatomy, the basic physiology of the heart, the cardiovascular system. So if I draw the heart here, and I'm actually going to try to do a heart-lung lab for you guys.
Nice.
We're gonna try to combine it with the intermediates though, with arts class. We'll do a combined lab. We'll also do an IV. What?
No, I was like, ooh, the intermediates.
Oh, I know. It's so terrible that the intermediates get the benefit from it. Yeah, so terrible. Yeah. But I do a lot of stuff with a microscope during that lab, and it's just easier to do it with as many people as possible. We'll do some blood typing, some antibody stuff. All right, so here's a heart, okay? Took a slice through it. Let's talk about the major structures. So what are these structures at the top of the heart? The atria, okay? Right, you've got your right, your left atria. Okay, what happens here in the right atria? Atrium.
What happens there?
You know what happens here?
Oh,
What's that?
Blood flows into the
Yeah.
superior.
Yeah, so blood comes in from the superior
vena cava.
vena cava, and where else?
The inferior.
The
vena cava.
inferior vena cava as well, or vena cava, however you want it. Inferior vena cava. You guys good with that? Okay, so deoxygenated blood comes in, gets dumped in here, and then what happens from here?
Goes through the tricuspid.
Right, so it goes through the tricuspid valve, right? Which has 3 cusps to it. All right, and it gets squirted into what? The
Right ventricle.
the RV, all right, the right ventricle. From the right ventricle, where does the blood go?
Out.
Out where?
It's the pulmonary. Yeah, it's the valve there, the pulmonary, semilunar.
Let me try to draw this a little better for you guys here. So here it is. All right, we've got a couple on the right, a couple on the left. All right, and then imagine that this is it. One out, okay. So it goes through what valve?
It's the pulmonary, semilunar.
The pulmonary valve, or the pulmonic valve, which is a semilunar valve.
Isn't there another name for it?
The pulmonic valve, pulmonary semilunar valve. And then the blood goes where? Into the pulmonary arteries. Okay, it gets circulated through the pulmonary circulation. Okay, hopefully it gets oxygenated, and then it comes back to what structure?
The left atrium.
The left atrium via the pulmonary veins. Okay, so it comes into the left atrium, and then where does it go?
The bicuspid.
The mitral valve. Okay, which is What's this here?
The left ventricle.
The LV. And then from the left ventricle, it goes where?
To the aortic valve.
All right. Through the aortic valve, I can't really draw that here because I kind of cut that away. But if you can imagine, it goes out of the aortic valve and it goes off out through what? The aortic arch, the aortic arch, okay, which is actually sits in front of the pulmonary artery, right? The aortic arch actually sits in front of the pulmonary artery, or what we call the pulmonic trunk, all right? And it goes out to the body. You guys cool with that? Does that make sense?
Yeah.
You guys good with that? Okay, let's just talk about some of the nuance now. There are a few layers of the heart wall. What are they?
The pericardium.
Okay, so the pericardium is where?
Pericardium. Oh, it's right there.
Pericardium outside, right?
Yeah.
What's in the middle here?
The
Nope.
no, it's the spade. That's the spade.
It's all the muscle, right?
Oh.
It's all those muscle cells that we just talked about, right? That's where all the magic happens. The myo, right? Myo means muscle, myocardium. When we say myocardial infarction, right? That's what we're most worried about is infarction of the myocardial tissue, this middle layer, because that's where the bulk of the business is occurring. And then on the inside of the heart, you have what? Endocardium. Okay. You have endocardium. And then surrounding the heart, you have a sac. It doesn't literally surround it like this. It actually is right on top of the heart. It's the pericardial sac. Now, the pericardial sac is not the pericardium, okay? We separate those two things, even though they really are kind of attached when you kind of peel things back. But the pericardial sac surrounds the pericardium. The pericardium's kind of smooth, kind of has a smooth, slick feel to it, and the pericardial sac kind of has a smooth, slick feel to it. And then there's just a tiny bit of pericardial fluid that lines that tiny little space there. And then as the heart beats, it's kind of lubricated and it can kind of be unimpeded. Does that kind of make sense?
So the pericardium is the actual outside.
The outermost part of the heart.
Okay.
It's not the pericardial sac. We actually separate those two, even though it's kind of they're kind of invaginations of one another, and it's kind of hard to tell where they begin and end. But when we go into our heart-lung lab, you can definitely, looking at it grossly, okay, looking at the big picture, you can definitely separate most of the pericardial lining, the sac, from the pericardium itself. So yeah, they are two different structures. Okay, you guys good with that? What cavity does the heart lie within? Okay, what subcavity? There's actually a section, if you will, of the thoracic cavity where the heart and the great vessels. Okay, the heart, the great vessels, and then that basically is separated by the hilum. Okay, where the vessels go out of the heart into the lungs, and the lungs into the heart. And that cavity is known as the
Substernal?
no. What is this area here? Okay.
Yes.
You guys know this. The mediastinal cavity.
It was escaping me.
Yeah, this is the mediastinum, right?
Yeah.
The mediastinal cavity. You guys good with that? Okay. Just basic stuff, guys. That's all. It's just basic stuff. I'm not, like I said, don't make it more complicated than it needs to be. I'm not trying to throw curveballs or anything like that. It's the mediastinal cavity. Okay. You guys are good with the valves. Let's talk about the heart muscle in just a little more detail. And like I said, I have some microscope slides that I'll prepare for you guys, and I'll do some staining, and that way we can actually look at the cells in a little more detail. But I'll just kind of draw you
Can I ask a
picture.
quick question?
a.
So is the parietal pericardium on the inside of the outside there, and the visceral is on the
Visceral, whenever we talk about visceral lining,
It's inside.
viscera means organ, right?
Yeah, so it's around the.
It
organ.
always is, so this would be the visceral part, right?
Okay,
Right, and this would be the parietal.
okay.
Right, and that would be the same with the abdominal cavity or whatever other cavity. Whatever is actually contacting the organ itself is visceral, and parietal is. Okay, so here is just a kind of a quick subsample, if you will, a little sample of what cardiac tissue looks like. All right, it's branched, which is very different from other types of muscle, right? We don't see that kind of that branching with other types of muscle. All right, and when you look at it, and we'll actually get a better feel for this in the microscope slides, there are actually these kind of thick lines in between the cells. And they're actually not striations. Striations are in the...
That's right.
Is it muscle?
These structures are characteristic of cardiac cells. They are special structures that are only associated with cardiac cells. Okay. And of course you have the nucleus. And mitochondria and all that stuff. Okay. But these structures are really important. This is known as an intercalated disc. Have you guys ever heard of that?
Yes.
What's the purpose of an intercalated disc? Why do we have them? They have small little pores in them, or what we call gap junctions, and what do they allow?
No, yeah.
Yeah, they allow for conductivity. They allow for conduction. So when this cell depolarizes, okay, when this cell depolarizes and that wave of depolarization is moving through it, okay, this junction here allows that sodium to rush through, depolarize this cell, and then rush through and depolarize those cells. So it's a way of facilitating proper conductivity. Does that kind of make sense?
Mm-hmm.
Right? Because the cardiac tissue needs to contract in a very specific way, right? It can't just be V-fib and every cell is contracting and doing its own thing, right? Because the heart wouldn't beat. It needs to contract in a way that the top of the heart contracts first, squeezes blood to the bottom, and then the bottom squeezes this way to push blood out, right? You can't have this part up here contracting before this part down here, right? Or you wouldn't get good contractility, you wouldn't get good cardiac output, et cetera, et cetera. All right. So these intercalated discs. Are you guys okay with muscle contraction in general? I think I went over, I think I actually talked about it with you guys, right? And when I covered for cardiology, right? What's that? Right, yeah, actin, myosin, tropomyosin, the Z-bands. You guys remember all that?
Yeah.
The Z-bands, the A-band, the M-line, the Z-line, the I-band, the thick and thin filaments. Okay, depolarization, T-tubule, sarcoplasmic reticulum, calcium, tropomyosin binding site, all of that stuff. Okay, you're gonna want to go back and review that stuff. Okay, there's a pretty decent picture in your textbook, your paramedic textbook, chapter 29, part 1. And it kind of uses like a gun analogy, and there's like a little drawing, and they pull the trigger on the pistol, and it kind of shows the ions flowing through the muscle. So if you're a real visual learner, that may be helpful. But either way, just kind of go back through that. And in fact, that's why I'm making you guys do the workbook for chapter 29, part 1, even though you technically already did it in EKG interpretation. What's that?
I said a review would be welcome.
Yeah, that's why I'm making you guys do the workbook, because it does make you go through the anatomy and physiology again. And there's actually some good, there are some good questions about medication administration and dysrhythmia management. So it's actually a worthwhile thing to do. So that's why on the day that you guys take your final, you'll turn your workbooks in and hopefully you will have done 29 part 1 and part 2. Even though technically we're talking more about part 2 in this class. You're still going to want to review that part 1 material because you still need to know dysrhythmias and meds, et cetera, et cetera. Okay, you guys good with that? Does that make sense, more or less?
And the intercalated disc was for conduction?
Right, has a gap junction, right? It has a little pore that allows sodium to rush through it. And basically it allows for the propagation of that wave of depolarization. And that's why if your SA mode fails, okay, say that this is maybe in the AV junction somewhere, right? This guy can still take over as a pacemaker because this guy can communicate with the other cells through those gap junctions, right? Now that communication is going to be different because if this guy's in the junction taking over as a pacemaker, obviously that wave of depolarization is going to be moving in the opposite direction, right? And that's where, obviously, you guys talked about this already, but that's where you get things like inverted P waves and all that with the junctional rhythm. Because that impulse is now traveling up toward, you know, if you're looking at your negative, whatever, your negative electro, like lead 2, if it's moving up here, it's moving toward the negative instead of toward the positive, and you get that inverted complex, or deflected complex. Okay, cool. Well, let's see. How are we looking? We're looking good. All right, so you guys good with this? I'm going to erase all this. Okay, cool. All right, so now let's kind of get down into the nuts and bolts in a little more of the nuance of the cardiovascular system. And really, what's the main role of a cardiovascular system?
To bring oxygen to the body.
Okay, yeah, so it's a way of pumping blood. Yeah, there you go. Yeah, just kind of the KISS symbol there, right? Keep it simple. Just pumps blood around, right? There's a lot more nuance than that, but let's just start there. We got to pump blood. And what I'm going to do is I'm going to make a quick analogy, and I'm going to try to simplify it a little bit. How are we doing here? Okay, good. And I'll give you guys a break in about 10 minutes, so don't worry. So let's try to simplify this a little bit. Yeah. So imagine I have a pump here. All right, some sort of pump. Yeah. Okay, so we're just going to make we're going to super simplify the cardiovascular system, because when we do that, we can actually understand things. So imagine that I have a pump here, all right? It's a little pump spinning around, and it's pumping blood, and blood is circulating through the pipe in this direction. Comes into the pump, goes out of the pump, and it circulates around. You guys cool with that? This is going to be the fundamental analogy of the circulatory system, okay? So the two basic components of the circulatory system are the pump, okay? Well, there are three, really. You've got the pump, you've got the pipes, and you've got the...
Container?
Yeah, the stuff inside the pipes, the fluid. Pipes are the container is another way of looking at the pipes.
Yeah.
Okay, you got your pump, you got your pipe, and you've got the stuff in the pipe. You guys good with that?
Sure.
This is just a water pump, really. This could be any sort of pump. All right. Now, the first thing that we need to understand is, how do I get that fluid to flow through these pipes?
You have to have power to your pump.
Okay, so my pump has to work, right? There's some assumption we got to make the pump has to work. But from a physical standpoint, okay, if I have a pipe here, all right, I have a pipe, and I have some fluid that I want to move through this pipe. What do I have to need on one end of the pipe and the other end of the pipe? What needs to happen here for fluid to flow one way or the other?
Pressure.
Okay, so let's say that I put this pipe under pressure and I have 100 millimeters of mercury pressure here and 100 millimeters of mercury pressure here. I've got my pressure. Is fluid going to move through the pipe?
No.
Why not? Oh, we're getting somewhere now. It's not just pressure, it is a difference in pressure. Right? It's a difference in pressure. There has to be higher pressure somewhere and lower pressure somewhere else, right? So if I went like this, 150, what way is a fluid going to move through the pipe? It's going to move this way. It's going to move from higher to lower, okay? It is, in essence, in a sense, it is a type of diffusion, if you will. Okay? So blood is going to flow, fluid's going to flow, because blood's a fluid, right? It is going to flow from areas of higher pressure to lower pressure. Okay? And in physics, the difference between pressures along a certain length of pipe, okay, could be a blood vessel, right, is what we call delta P. Okay, a triangle, that's just delta, right? Well, Greek means delta, it's D, alpha. It roughly means D in the alphabet. And delta just means change, okay? My change in pressure, or you could look at it as a difference in pressure, okay? That's also known as a driving pressure in physiology. That's called a driving pressure, okay? It drives the flow of a fluid. This concept is critically important in cardiovascular medicine, and it's critically important in pulmonary medicine because it is the same principle that drives air in and out of the lungs, okay? We need to have some sort of delta P. You guys cool with that? Mm-hmm. So the pressure cannot be the same at every point along this pipe, right? The pressure has to be really high here, and it has to be what? It has to be lower here. Okay? If this is not the case, I'm not going to have normal flow through the system. You guys cool with that? Mm-hmm. Does that make sense? It's a very fundamental concept, and I think there are a lot of people that maybe don't necessarily articulate that very well when we talk about the circulatory system. Okay? You got to have driving pressure. You guys cool with that? Okay, so now that we have that concept solidified, what I want to do real quick is I just want to talk about blood pressure, okay? So when I check somebody's blood pressure, what is that telling me?
The highest and the lowest pressures in the vascular system.
Okay, so it is a reflection, blood pressure. It is a reflection of this process occurring here, okay? And what I want to do is I just want to dive into that concept of blood pressure. Because I think you guys all are familiar with systolic versus diastolic, right? The top and the bottom. But I don't think that we look at it as dynamically as we should, okay? I don't think that I think there's a propensity, and this is just the human brain trying to make things simple, right? You guys are familiar, anyone taking psychology here? You guys familiar with something known as the Gestalt proximity phenomena? It's how printers work, right? Like if you like let's say I have a line, right? And I print a line, well, is it really a line or is it a series of tiny little dots? And your brain looks at that and, you know, it kind of connects the dots a little bit. It's gestalting it, if you will. You ever heard that term? Gestalting it, kind of simplifying it. And I think maybe not you guys. In the case for me, when I first started learning this stuff, and I actually got my EMT in the military, which, you know, the military is a little, there's not a whole lot of elaborating on stuff. It's like, this is how it is, don't ask questions, let's move on. So there's this propensity, I think, when we check somebody's blood pressure, we just think, oh, that's the pressure in their vessels, right? And we tend to overlook the fact that it can't be the pressure in the entire system, right? But more, it's a reflection of a highly dynamic process. So we're going to dive into this concept of blood pressure a little bit. Okay, so when I check somebody's blood pressure, there are a couple things that go into blood pressure. Okay? There are two major concepts that we look at that gives us our blood pressure. The first concept is, would you guys agree that the pump needs to be pumping something out? If the pump is not pumping something out, I'm not going to get any pressure anywhere, right? You guys cool with that?
Yeah.
So the pump has to be pumping something out, okay? And in physiology, we call that cardiac output. Yeah. Cardiac output. So I have to have cardiac output. My pump needs to be pumping something out. You guys cool with that?
Mm-hmm.
Another thing is I have to have some sort of resistance. Okay, I have to have some sort of resistance as that stuff that's being pumped out, it's being pumped into something, right? And when I pump blood, let's say into a vessel, there's some sort of resistance to the blood flow through that vessel, right? Does that make sense? There's some sort of resistance. If there's no resistance at all, then would we have any flow? Would we have any differences in pressure or anything like that? No. So I also have to have basically resistance in my arteries, or arterial resistance. Arterial resistance. And somehow these two big concepts here are what give me my blood pressure. So let's dissect these in a little more detail. What do you guys think? We'll dissect these in a little more detail and we'll talk about them. So let's do a different color here. All right, so going back to basic and intermediate school, what are the two fundamental components of cardiac output?
Rate and volume.
There you go. So I need to have heart rate, all right, and I need to have what else? Stroke volume. Heart rate and stroke volume. And in fact, this brings us to the first fundamental formula that you guys have got to remember, all right? And that is cardiac output equals heart rate times stroke volume. It is a product of heart rate and stroke volume, okay? You guys cool with that?
Mm-hmm.
So if I have a heart rate of 50 beats per minute, all right, and I want to know what my cardiac output equals in liters per minute, and my stroke volume is 100 milliliters per beat, can I calculate my cardiac output? Yeah, I just plug and chug. So 50 for my heart rate times 100 is what? 5,000. Is that the answer?
Liters per minute.
Yeah, this is in milliliters, right?
Mm-hmm.
This is 5,000 milliliters per minute. If I ask for liters per minute, you guys got to remember, you've got to convert this to liters, which is 5 liters per minute. You guys go with that?
Mm-hmm.
Okay. What is the normal cardiac output in an adult? Approximately, we'll say.
What about 5 liters per minute? 5 to 7.
Yeah, about 5 to 7. All right, so 5 to 7 liters per minute, roughly normal. You guys good with that? That's your first fundamental formula. You got to know that. It's the product of heart rate and stroke volume. Okay. So heart rate. Well, what kinds of things go into having a good heart rate? The major thing is chronotropy, right?
Yeah.
Okay, chronotropy. All right. And is it too fast? Or is it too slow? Either or can be a problem, right? Now you might think that fast is good, right? Because if I have a heart rate of 50 and a stroke volume of 100, and then I increase the heart rate to 100, well, what's my cardiac output go to?
10.
10 liters per minute, right?
Mhm.
So it makes sense that, well, if I just keep going up on my heart rate, then I'll just keep going up on my cardiac output, right? Is that the case? What's the problem with that way of thinking?
Fluid needs time to move.
Yeah, you're on the right track. At some point in an adult patient, it's somewhere around 150 beats a minute. At some point, the heart is moving so fast, it's beating so fast, there's simply not enough time for the ventricle to fill with blood. And if the ventricle doesn't fill up with blood, then there's no blood to pump out, right? Okay, so at some point, this heart rate times stroke volume formula breaks down. In an adult patient, it's somewhere around 150 or so, okay? That's kind of a rough number, 150, 160, maybe a little higher, maybe a little lower. Might take a little more time in some people, might take less time in others, okay? You guys go with that?
Mhm.
Now, stroke volume, this is a tricky one. But basically, stroke volume comes down to two things. And we'll do a different color here. It comes down to the volume that's right here. In diastolic volume. Okay. So this is the amount of blood in the ventricle at the end of diastole. You guys good with that? And in systolic volume. All right? These two things are what make up our stroke volume. End systolic volume is the amount of blood that is left in the ventricle at the end of systole. Okay, so what happens during diastole? What happens during diastole?
Ventricles fill?
Right. What fills the ventricles?
The squeezing of the.
The blood from the ventricle.
Atria, right? The atria contract and they pump blood into the ventricles. Okay? So at the end of diastole, hopefully what has happened?
The blood's moved. Oh, diastole.
At the end of diastole, hopefully what has happened? Yeah, the maximum amount of blood has been pumped from the atria into the ventricles, right? Okay, so at the end of diastole, do you want this volume to be large or small? Large, right? You want full ventricles.
Yeah.
You want full ventricles. You want a large end diastolic volume. And at the end of systole, what do you prefer? A large or small systolic volume? A smaller systolic volume, right? Does that make sense?
Mhm.
You want to fill the heart up, and then you want to pump the blood out. There is a concept in medicine that is measured. We actually measure this when we do an echo on our patients. Okay? You'll see this written in charts, and this is known as the LVEJ, or some people just call it the EJ. That is the left ventricular ejection fraction, or the ejection fraction. And have you ever heard of patients, or have you ever heard of people talk about this value? Now you're going to know what it is. The ejection fraction is the percentage of blood that gets pumped out of the ventricle. The ejection fraction is the end systolic volume. So if I have an ejection fraction of 0.25, that is 25%, right? What does that mean?
25% of the volume in the ventricle is the left.
That means only 25% of the total volume is getting pumped out of the ventricle. Do you suppose that's a good or a bad thing? It's a bad thing. Only 25% of what gets pumped into the ventricle is getting pumped out. That means something's going on with the left ventricle. It's not able to pump blood out. However, if I measure, say, 68%, or 0.68, that is going to be better or worse than 25%.
Better.
It'd be a lot better, right?
So the percentage is what's pumped out.
Yes, right. So basically what that says is if I have 100 if my end-diastolic volume is 100 milliliters, okay? My end-diastolic volume is 100 milliliters, and I measure the ejection fraction, and it's 0.25 or 25%, how many milliliters of that's going to get pumped out? 25 milliliters. Does that make sense? It's 25% of whatever your end-diastolic volume. Does that make sense?
Yeah.
If it's 50, if your ejection fraction is 50%, that would be 50 milliliters, okay? And generally around, 50 to 75%, more or less, is a normal ejection fraction. Anything significantly less than 50 is going to be a problem. And if it's significantly higher than 75, that's potentially a problem too. Okay, because your left ventricle shouldn't completely be emptying. Okay, there should be a little bit left in there. And we'll talk about some of those issues in a little more detail. But are you guys okay with that? Does that make sense?
Mm-hmm.
And so really it's the difference between these two. Okay, whatever the difference is right? If I have 100 here and 50 here, okay, that gives me an ejection fraction of 50%. You guys cool with that? Does that make sense?
Mm-hmm.
All right. Generally, the lower your left ventricular ejection fraction is, the worse off you're doing. Okay? You guys cool with that?
Mm-hmm.
Okay. So what goes into my end-diastolic volume? What kinds of things would give me a good end-diastolic volume? What kinds of things are going to ensure that my left ventricle gets loaded up with blood? Just sit on the chair so I can get down the lower. You guys think?
Strong contraction, like
Contraction of what?
atrium.
The atria, right? So my atria need to be working.
Mm-hmm.
Okay. What else?
You need the,
You need the volume.
Say it again.
The volume?
I need blood volume, right?
Yeah.
I need to have a container that's got blood. I need blood volume. So if I get all dehydrated or I lose a lot of blood, right, I hemorrhage it out, my end-diastolic volume is going to be pretty terrible, right?
Yeah.
Does that make sense? Yeah, so my atria need to be working, and I need to have good volume in my vessels.
and you need AV junction to hold the beat for you. So that way you're,
Right, I need time, right? I need time going back to here. I need time for the ventricle to fill. Absolutely. And there needs to be enough time for that ventricular filling to occur. What do you suppose goes into here? What's the big thing here? What needs to be going on in my end-systolic volume? What needs to be working for me to get all that blood pumped out of there?
the pulmonary system needs to be available to take more blood.
Maybe.
Contraction.
There you go. I need the left ventricle needs to be able to contract, right? I need to have contractility. Right? I need to have contractility. That ventricle actually needs to work. It needs to do its job. You guys cool with that? Let me go for just a couple more minutes and I'll get you guys out of here for a little break. So, there is a concept here that I want to make sure you guys are all up on. And it's not completely obvious looking at this picture here, but let's talk about it. That is something known as the Frank-Starling mechanism. What is the Frank-Starling mechanism? Frank-Starling mechanism.
How hard the heart can contract?
Sort of. Also known as Starling's law. What does that mean?
The stroke volume of the heart increases, like in response to an increase in blood volume.
Okay, you're on the right track, definitely. Let's make sure that we can visualize this. Basically what this means is, you can imagine that your left ventricle is a rubber band. And your right ventricle to some extent too. But since it's the left ventricle that is most of the cardiac output, we'll talk about that. So if I happen to stretch that left ventricle out a little bit, what's going to happen when it contracts? Bam. What if I stretch it a little more? It's going to contract even better. So part of what goes on here, and it's not entirely obvious, is I need to be able to stretch the ventricles out adequately when I fill them. And the fact that I can stretch them out will make them contract even better. So in general, okay, the better my atria work, the better my atria can preload, can load those ventricles up, and the better or more efficiently those ventricles can contract, okay? That's known as the Frank-Starling mechanism of the heart, or Starling's law. And if I have good preload, I can stretch the ventricle out, load it up, okay, it's going to beat better. Now, is there a point at which I get into a diminishing return situation? There is, yeah. There's a point where you can overstretch the ventricle, and then you're not going to get increased contractility. You're probably going to actually get decreased contractility. Yeah, things are not going to work very well. Okay, so there are general rules or rules of thumb, but you've got to remember the exceptions. Okay, like the heart rate times stroke volume equals cardiac output is the general rule of thumb, but there are exceptions such as my heart rate being too fast and not having enough time for ventricular filling. Likewise, the Starling's law is a general rule of thumb until you get to the point that you are overstretching the ventricles, and then you won't get that increase in contractility. You guys okay with that? Just real basic foundational stuff, but we need to get that stuff out of the way. Okay, take a 5-minute break.